And let us know here in just a sec. Yep. Ready, Freddie.
Okay, thank you. So welcome everyone, and thank you very much for coming to PCEP. I welcome any questions as we go throughout the lecture. You can either put them in the chat or raise your hand on Teams. And so today we're going to be talking about the balancing acts that we do as we deal with medical legal issues in EMS. But before we dive into the meat of the lecture, I just wanted to give kudos to the system as a whole. I was presenting to my partners last week about cardiac arrest and had the pleasure of sharing this data from 2021. This is our cardiac arrest data for the Utstein survival, meaning the patients are presented with a shockable rhythm. And so for Clark County, out of all the patients that presented with a shockable rhythm, 54.5% left the hospital alive with good neurologic function. In the cases where there was bystander CPR, that was 60.9%. That's compared to, for the state of Washington as a whole, 36.8, and nationally 29%. And so, I mean, or to put that in human terms, out of the 33 patients that presented with shockable rhythms, 18 of them walked out of the hospital alive or with their families. And that's just a tremendous accomplishment that reflects the dedication and the hard work that you all have done. And I just wanted to express my gratitude for that. So in this presentation, I am using cases drawn from Clark County. So as with case review, confidentiality applies to this lecture. So we're going to talk about capacity and refusals. We'll talk about management of the agitated patient with special attention to the changes that have happened since we last gave this presentation. We'll talk about suspected abuse and crime scenes, hit the highlights with respect to documentation. And then we'll finally tackle a separate issue and talk about the interactions between midwives and EMS. So when we talk about capacity and we talk about a patient's ability to refuse, we're talking about a balancing act because we're trying to balance the medical risk to the patient against the patient's right to self-determination. So we'll start with two cases. I'm going to go ahead and read for anyone who might be having trouble seeing this on a small device. So this is a narrative from a patient. They were dispatched code 3 to an unconscious diabetic, 66-year-old, 75-kilo female, chief complaint of hypoglycemia. Family stated the patient had not had breakfast yet, was sitting on the couch, became unresponsive, fell to the ground, diaphoretic. Had never had similar signs and symptoms before, no recent med changes. Patient, after the patient woke up, had no complaints, says she feels fine now. It denies any other signs or symptoms, and no injury from the fall, and was declining transport and evaluation. Says she took insulin in the morning, but had not had breakfast yet. And so, and then they described that they arrived to find the patient supine on the floor, ABC's normal, snoring, but snoring respirations, not responsive, improved quickly with IVD-10, quickly became asymptomatic and refused transport. They told the patient and family to call 911 if any signs and symptoms return, or if the patient changes her mind, wants transport to call 911 again, sign the refusal. And then they witnessed the patient eating eggs and toast prior to leaving. Case 2, responded to a patient that was more tired than normal. The family stated the patient went to neighbor's house, was not sure what she'd had, but came back home and was more tired. The patient had denied drug use. The neighbor called and stated that the patient came over, had a glass of wine. Arrived to find the patient in no apparent distress, resting on her bed. Patient denied any chest pain, shortness of breath, abdominal pain, headache, or nausea and vomiting. The patient did not want to go to the hospital by ambulance. Patient was advised that an evaluation by EMS does not replace that of a physician. Transport recommended. The Patient understood the risks of refusing and signed a refusal form. Patient advised to call back if she changes her mind or a condition worsens. Patient was left in the care of family. And so we'll come back to these two cases in light of the stuff that we review, and I want you to think about, how would you write this? What else? What do you want to see in this chart? What's done well here? So lawyers talk about competence, and in medicine we talk about capacity. So competence is a 3-step legal test. It's determined by a judge about whether the individual can retain and comprehend the relevant information, can they believe the information, and can they use that information to make a choice. Capacity is something that we establish in medicine. It can be a presumptive determination of competence, meaning that if someone lacks capacity, it's likely that they will lack competence. But capacity is also a shifting definition because capacity depends on what exactly the patient is accepting or refusing. So it depends on the significance of the decision being made. And you think about these two cases, what are the risks of refusal in each of these two cases? You might have a different standard for a capacity for a patient that has an abrasion on the hand than a patient who has a stab wound to the chest, or a patient that's having severe chest pain. So with those higher risk complaints, there's a higher burden to show that they really understand the risks and the benefits of the decision that they're making. So for a patient to give informed consent or to make an informed refusal, what do they need? They have to be given the accurate information about the possible medical problems and the risks and benefits of the treatment or the refusal. They have to understand and be able to verbalize the risks and benefits, and they have to be able to make a decision. And this decision would be consistent with their beliefs and their life goals. And so it doesn't have to be the decision that you would make. It doesn't even have to be a particularly wise decision, but it has to be a decision that's consistent with what they believe. So how do we approach this if we have a patient or a decision maker who has capacity, and then we ask, what is the medical need? So if there's no medical need, you called for a concern that doesn't appear to exist. I thought the patient was in a car accident. They weren't in a car accident. The patient's not interested in care. There's no need. You document your conversation and what happened and how you determined that there was no medical need. What if there's a minor medical need, suturable laceration, well-appearing kid with a fever? Then you document a chart and you document a refusal form. Just a brief note about the refusal form. We do ask for the refusal form. The refusal form does not replace the conversation that you have with the patient. It's a formal documentation of the conversation that you have with the patient. But if we had to choose, or you had to choose in a court of law between having no refusal form but a carefully documented conversation in the chart, or having a refusal form but no carefully documented conversation in the chart, you're much better having that careful documentation in the chart. And ideally what we want is both, but we understand some patients can't, some patients won't sign. But it's the documentation that you put, that you address those elements, how you determine the capacity, how you determine the medical need. That's the valuable thing to have in the chart. And then what if there is an immediate need for medical care, and the patient or the decision maker has capacity and is refusing care? Then you're going to do a chart. You're going to contact medical control as another attempt to try to convince the patient to accept medical care, and then document the refusal form. What if there's no decision maker with capacity? And this is where I have to, although there are more experienced people on this call, I have to feel this makes me show my age, because I think when I started off in EMS, we really thought about this differently. We just thought, well, if they don't have capacity, we're just going to wrestle them and take them. And our approach to that has evolved. So if medical care or ambulance transport is necessary, then we're going to do everything within our power to try to get the patient to go. Solicit assistance from family, friends, solicit assistance for law enforcement, if appropriate, or a mental health professional. You can consider clergy. Um, if medical control concurs, you could consider physical restraint and sedation. But this is something that we want to approach very cautiously. And then we would do that when the patient poses an imminent danger to himself or to others. If you don't have a decision maker with capacity, we ask that you consult medical control, and then the disposition is treated released against medical advice. The governing principle here is that we don't want to put you at risk, and we don't want to put the patient at risk by getting into a fight when we couldn't safely restrain the patient. What if law enforcement is involved? So law enforcement involved, the patient not in custody, then the patient is still the decision maker. Patient can refuse care or transport. If the patient is in custody, the patient can choose to accept or refuse care, but the patient can't choose the location of their incarceration. So if the patient is on a police hold for a legal reason, and there's a medical need, then the patient can be transported against their will to be evaluated. Still in the hospital, they can accept or refuse certain elements of care. But if the patient needs medical clearance to go to jail, the patient cannot choose to go to jail without medical clearance. If any question, so for example, if there's a minor medical need, but the police officer feels that they can take them to jail, and you agree that there's nothing that needs hospital evaluation, then the police officer can sign the refusal form. If failing that situation where you have a minor medical need, transport the patient to the hospital by ambulance. If there's an obvious medical need for ambulance transport, we wouldn't allow police to transport. So in a refusal, which is one of the highest risk things we do, what do we need to document? The patient's chief complaint, the events prior and the reason for the call to EMS, the pertinent medical history, a relevant description of the scene, physical exam, including vital signs. If the patient will not permit vital signs, then document what you see, that the patient was ambulatory, well perfused, with no respiratory distress. Clinical impression, pre-hospital interventions, consultation with medical control as needed, and the attempts that you made to convince the patient, and in the instructions that you left with the patient or family. So let's come back to case one and think about that in light of the things that we refused. So is there a medical need here? The patient was unconscious. We seem to have a pretty reliable understanding of why the patient got hypoglycemic. This is someone who on insulin, took insulin, and did not eat breakfast. So we have a reason that the patient got hypoglycemic. It is helpful with hypoglycemia to have documentation if the patient is on any oral agents, because those tend to be far longer lasting than the insulin. But what happened on the call is clearly described. It's clearly described that the patient is awake and alert, has the capacity to understand the risk. They've documented what to do if any signs or symptoms return, and then they've given this extra piece of really strong documentation that they watched this patient eat a meal with complex carbohydrates, protein, and fat. So, really strong documentation of a patient who received care, refused care. What about case two? So here we have the complicating factor that the patient admits to drinking alcohol. And so does that mean that she automatically lacks capacity? Not necessarily, but it really helps to have documentation when there's exposure to a substance or an intoxicant that the patient doesn't appear intoxicated. You can document with that with things like clear speech, normal gait. Um, that it helps to document why the patient, why, although the patient has had some wine, the patient still has capacity. That said, it's a pretty low risk chief complaint to be a little bit more tired than normal after having drunk some alcohol. So the burden of proof is much lower than if the patient was complaining of chest pain or had a dangerous mechanism of injury. The other thing, so this, they've documented that the patient was advised that the EMS evaluation does not replace a physician evaluation. They do document that she understood the risks of refusing and advised to call back. And then the other strong piece of this documentation is that it pulls out that the patient was left in care of the family. So it does, you could, in a situation like this, say the patient is intoxicated, you could use the family as a proxy decision maker, but it helps to kind of document your reasoning. Is what you're saying in this case the patient had capacity? Are you saying that the family had capacity and refused on part of the patient? So this covers the needed elements. There are areas that can be stronger. But because it's a relatively low risk chief complaint, it meets the necessary criteria. Any questions about those two cases?
Dr. Mock, I have a couple of questions, only that obviously this is this is a very edited chart. As for an example, how old was this patient? Were all the vital signs in the chart normal? Did they check a blood glucose, for example? Did they do anything? Is there anything that shows that they actually did an evaluation?
Yes, no, you're correct. I just pulled the narrative out of the chart. So this was a 62-year-old woman who had normal blood glucose, normal vital signs, and had a full normal exam documented. And the exam does note that the patient, was ambulatory. Didn't specifically comment whether she was ataxic or not, but there's a full exam documented. And a full evaluation was done on this patient.
I'm assuming that I was assuming that was the case. I was just establishing that. It's just that this is of course, after being in the business for 50 some years now, it's I've seen everybody. I mean, would you call 911 if somebody in your family said, "Boy, I feel more tired than usual"? I mean, I don't know. What was it about this person being more tired than usual that was significant enough to get a 911 call?
Yeah. No, and I agree. It would help to color that in the chart. That said, people do call 911 for all sorts of things. No, but I agree. Any detail that you can give on the stuff that just doesn't quite add up really helps, especially when we're reviewing the chart. Other questions about these cases? Okay, we will move on to management of the agitated patient. And these are cases in which we're balancing, we want to give patients the autonomy possible, but we also are facing a potential risk to public safety. And this is a landscape that's really changed, particularly in the last 2 years, because the citizens of the state of Washington, through their legislature, have changed the rules of engagement for police around mental health. And so that's necessarily changed the environment that we're operating in. And so I'm going to go through a couple of cases that that illustrate how we're managing this. So case 3, and again, I will read. So the unit was called to the parking lot behind the share house for a female who was suffering from a behavioral health emergency. They staged away from the scene, and then Cresta advised VPD was requesting EMS enter the scene. The officer stated he would like to put the subject on an ITA, but would not be able to physically restrain the subject. They made contact with the subject face-to-face, attempted to de-escalate verbally, asked the subject if she would allow us to evaluate her. Subject was yelling, speaking mostly incoherently, requested a pair of pants, which she told her we could provide her at the hospital. Subject started to walk with us towards the ambulance, but then veered away and started yelling and screaming again. Continued to try to have the subject allow us to help her, but she refused. Then picked up a large metal pipe that was nearby while yelling at us and VPD. VPD yelled at her, told her to put the pipe down, which she did. VPD stated that they would not detain her or physically restrain her in any way. The subject continued to refuse to cooperate or allow us to help her. VPD stated they were leaving the scene and advised we do the same. We left the area and contacted an on-duty supervisor. Supervisor advised we should clear the scene and not attempt to re-engage with the subject because we did not have support from law enforcement. Called Adult Mobile Crisis and spoke to Sadie via phone. Sadie said she would make a report, but did not think they would be able to respond. Advised AMR dispatch we were clearing the call and attached the Clark County EMS behavioral emergency checklist. And then I'll move on to case 4. So this is a patient in police custody. VPD states they have a history with the patient. Patient has a known psych history. Tonight, the patient assaulted an unknown number of people and then confronted the apartment complex manager and held one person hostage. No other details given to EMS. Patient was taken into custody using force. VPD requesting the patient be taken to the hospital for medical clearance. Found a 30-year-old male lying right lateral on the ground with his hands cuffed behind his back and a blanket over the top of him. Patient appeared to be aware of EMS arrival, otherwise had a feral look in his eyes and no interaction with EMS. First responders on scene stated the patient appeared to have excited delirium, and patient was given both Haldol and Versed to calm down. First responder had monitored vitals until EMS arrival. VPD stated that the patient was going to be taken into custody, and they asked that the patient remain in handcuffs, and VPD would be remaining with him in the ambulance. The patient had a small hematoma to the left eyebrow. Unsure if that was there prior or happened during the time the patient was taken into custody. Patient stood, sat on a gurney, hands were cuffed to the gurney rails, feet were placed in soft restraints. Patient did answer yes and no questions, did not appear appropriate to the question. Vitals were obtained. VPD requested transport to PCEP Southwest. They were on divert. Transported Code 1 to Legacy Salmon Creek with VPD rider. The patient remained quiet throughout the ride. Once in the room, patient was moved to the bed. Patient then started threatening both staff and VPD. Care was transferred to the nurse with no changes. So I will we'll talk about how we manage these, review the changes in the protocol, and then come back to these cases. So we have an escalating approach depending on the degree of agitation and the degree of threat. So we've added olanzapine as a measure for patients with mild agitation and psychotic symptoms. And I've seen this used and I've seen it be very helpful. It's just important to note that this is not for anxiety, but really for psychotic symptoms. It's typically the patient that's a little bit paranoid, wary. You can just give you this kind of bad feeling, but they're willing to take oral medications, and it's an oral dissolving tablet. You're going to start to see some effect within 10 to 15 minutes. It's going to have its peak effect by an hour. So you're setting yourself up for a safer transport and setting the hopefully shortening the hospital course by using that. In the patient with moderate agitation that does pose a threat, Unknown or suspected psychiatric, our preferred agent is droperidol, 5 milligrams IM or 2.5 to 5 milligrams IV. If it's drug intoxication, particularly sympathomimetics like cocaine, methamphetamine, or the patient is withdrawing from alcohol or benzodiazepines or is postictal, then Versed is the preferred agent. And then for patients like that in case 4 with severe agitation that are posing a risk to themselves and to others, we'll use droperidol 10 milligrams IM with Versed 5 milligrams IM. As a reminder, physical restraint is the minimum level necessary to ensure patient care, safe transport, evaluate and document the cardiac and the respiratory status. So coming back to these two cases, so how does case 3 fit into this? So clearly, this is a patient that does have agitation. And this is a patient that, several years ago, the police would be much more willing to engage with and cooperate to restrain. We're being asked to take, the police are being asked to take a more hands-off approach, and we have to alter our approach accordingly. I appreciate this crew documented very thoroughly what was happening on the scene. They documented what the police were saying and how the police were approaching this patient. And clearly there was the risk that this patient would pose a threat to other people. She picked up the pipe, but then she did obey the police command to drop that. And so the police did not feel like they could safely engage her, that the risk would be too great. The patient's not actively posing a threat to anyone else. And so the crew very appropriately withdrew, very appropriately documented everything that they did, and got mobile crisis involved. It's our mobile crisis has continued to beef up their staffing, and our hope is that this will continue to be more helpful and that patients can be engaged by them. We do have numerous examples where we have backed off and then mobile crisis has later been able to engage. But I appreciate the careful documentation and the careful decision making that went into this call. That's obviously very nerve-wracking. Any questions or comments about this case? And then going back to case 4, here's an obviously different situation because the patient is posing an active threat to other people, has assaulted numerous people, has taken someone into custody. And so this patient appropriately got an antipsychotic plus Versed. And then they appropriately document how the patient was restrained and what went into that. So obviously these are the two ends of the spectrum, and I think the more you get into the middle, the harder it gets. But our ask from you is that as you're making these tough decisions in real time, document the thinking that went into this and why you felt that either that the patient did not represent an immediate threat to themselves or to others, or why you did feel that the patient represented an immediate threat, and then how you made that decision. Any other questions or comments about that? Okay, we'll move on to a quick review of suspected abuse and crime scenes. Okay. So you have a very challenging role in that you're seeing patients in their own environment and you're making the initial contact. And so there's this fine balancing act between being suspicious enough to suspect a case of abuse that's subtle without being overly suspicious and engaging things inappropriately. When in doubt, we want you to err on the side of suspecting abuse. But then, and so as a reminder here, things that might make you think of abuse. If probably the key thing is that if the mechanism doesn't really line up with the actual injury that you're seeing, there's certain injuries that are very suspicious. Cigarette burns, a circumferential burn of the arm as from being put in hot water, bruises of varied age, belt marks. As a reminder, when you're evaluating kids, if you can't cruise, you can't bruise, meaning that kids that are not getting, that are only crawling, really can't have a tough time getting enough force to get bruises. Once they start pulling up on furniture, things like that, they can fall and they can get bruises. But those are typically, things on the knees, not big bruises on the back. A history of repeated injuries. The caregiver can place blame on others. A delay in seeking aid should make you suspicious. Remember that sexual abuse can accompany physical abuse, but it can also be present without signs of physical abuse. Evidence of medical neglect, unexplained trauma, and malnourishment are all things that either for pediatrics or especially for the vulnerable geriatric population, we need to consider. And I think one of the things that has happened as a result of the pandemic is that the long-term care facilities have had a much harder time recruiting staff. And so we see more and more vulnerable elderly patients living in the community. And you often get this insight that no one else can get by being able to evaluate them in their house. So how do we approach this? So treat injuries as per protocol, document and report as carefully as possible the caretaker's description. Having testified in a number of these cases, I really like to document what I asked and what the caregiver responded. But also to make careful documentation in the environment, noting who's on scene, and then if there's a question where you feel the patient should be transported and the caregiver is refusing, that's a good time to involve medical control. If the caregiver, if you suspect abuse and the caregiver is not allowing transport, notify law enforcement. And it is important because it is difficult to know when you have the suspicion whether you're ultimately right or not. It's important to be non-judgmental. As an example, saying, I notice there are a lot of different bruises here, a lot of bruises of different age. I think it's important that we get this checked out, but there's no need to explain why that happened. That can happen for a medical reason as well. And then obviously notifying the receiving hospital of the abuse or neglect. In EMS, we're mandated reporters. Any other questions about child or elder abuse? Okay. And then just brief reminders with crime scene response. Be conscious of the environment around the site, limit the number of personnel and vehicles entering the site, note the location of any furniture, weapons, other articles, and do not remove any debris that you generate on the scene. Write down any statements that you gather on scene, note what the patient's wearing on scene, and then place the patient on a clean seat when you're ready for transport. These are any cases where there's a suspected crime, worth taking a little bit extra time to document anything that you can remember. You'll never remember as clearly as you do right after the case. And if particularly if you have a high concern, it's also appropriate to fill out an incident report. Any other questions about crime scene response? Okay. We'll do a brief review of documentation, and then we'll move on to we'll cover the take-home points, and then we'll talk about midwifery. So with documentation, the balancing act is that we want to be timely, but we want to be thorough enough to hit the key elements. So one of the things that we've changed within the last several years is that we are asking for a chart documenting mental status, vital signs for public assist and lift assist. And again, I just wanted to express my thanks for how carefully this is being done. I can say I've seen a number of patients at the hospital, who were called for lift assist. We found new onset atrial fibrillation, a stroke, hyponatremia, anemia. So just keeping in mind that patient being unable to get themselves up off the ground is potentially a warning sign of a medical problem. But I've just seen multiple examples of this being done very well. To go back to that, patient contact occurs when you contact or see or hear a patient. So even if you're not able to lay hands on the patient, you can still document a patient contact and just document what you observe. If you are only assisting with patient moving or packaging, then we defer to your agency protocol. But with the caveat that if there's any question in your mind, you're much safer documenting what you did. Obviously, all reports completed prior to the end of the shift, and then transport agencies sending the final medical incident report to the receiving facility within 24 hours of patient arrival. So here are the things that I'd like you to take home from this review of the medical legal issues. So an individual with capacity can refuse care after the risks are explained. It really helps when you document and chart how you determine that they had capacity, how you explain the risks, and what you did to leave them in a safe situation. For agitated patients, decision-making on how to approach is based on the degree of threat, particularly the degree of threat to others. With respect to abuse, be alert, but non-judgmental in your approach. And then with respect to documentation, well, being timely and covering the key elements. And as we dive deeper into the KPIs, we'll give you more information about the specific things that we're looking for. But that as we demonstrate to other people the care that our system gives, that kind of documentation helps us all get credit for the work that you're doing. Any other questions about medical legal before we move on to midwifery? Okay. So this will not be the last time that we talk about EMS midwife interactions, but we wanted to give some background in light of a couple of challenging calls recently, and give more background on what midwives can and can't do, and then best practice when we're interacting with midwifery on home births or births in a birthing center. So I'm going to give some background on what midwifery is, what their scope of practice is, and then how we can best work together to improve patient care. So midwives are medical professionals that are licensed by the state. There are, we could go into greater depth, but there are essentially two pathways to becoming a midwife. So there are certified professional midwives, and this is what's called direct entry into the profession. So they get training in the nursing care that's necessary for women and infants. There's 3 years of didactic and clinical instruction at the post-high school. At a minimum, they have to attend 55 births. They also do newborn screening and well women visits. They have to pass an exam by the North American Registry of Midwives. And a certified professional midwife will typically attend births in homes and in birth centers, but not in hospitals. A certified nurse midwife has both education in nursing independently, and then midwifery. So there's at baseline an RN that has a master's or a doctorate in midwifery. There's a national board that certifies certified nurse midwives. The majority of certified nurse midwives work in hospitals, although they can also attend births in homes and birthing centers. But most likely, when you're encountering a midwife in the field, you will be encountering a certified professional midwife. So what are the risks associated with home birth, and how do midwives help mitigate those risks? So this is from CDC data about all home births, and then comparing those to hospital births that are attended by a certified nurse midwife. So this is infant mortality per 10,000 live births. So if a woman is giving birth in a hospital attended by a certified nurse midwife, 3.3 infant deaths per 10,000 live births. For all planned home births, infant mortality 13.7 per 10,000, and for an unplanned home birth, 28 per 10,000. So obviously the highest risk thing, and keeping in mind most births proceed normally and go well, but the highest risk thing is having an unplanned home birth. Having planned this, having a midwife in attendance definitely decreases the risk. And does it matter if it's a certified nurse midwife or a certified professional midwife? There's not a significant difference. So mortality per 10,000, roughly 10 for a certified nurse midwife giving birth at home or attending a birth at home, or 12 for a certified professional midwife attending a birth at home. So why am I presenting this? The point is, so compare these numbers to what happens in a hospital if you're attended by a certified nurse midwife. The biggest risk factor is that you're doing this outside of a hospital setting. So it's not so much the person that's attending, as home birth has attendant risks. And it just means that in those times when things go wrong, you just have fewer resources available, and it's more challenging to get to those resources. And so that's obviously where EMS comes in. So how often are patients transferred to the hospital from a birth center or from a home birth? So looking at national statistics, from birth centers, between 13 and 27% are transferred. The vast majority of these, even some early in labor, go by private vehicle. And so the number of EMS transfers is relatively low, somewhere in the single digits. Before the pandemic was in the range of about 1%. And then from home, range is from about 10 to 32%. And unsurprisingly, the things that indicate a transfer are most commonly blocked labor dystocia, secondarily fetal distress, and then postpartum hemorrhage. So, so these are the, when you're getting your mind ready for what you might be seeing on a home birth, most likely you're going to be seeing blocked labor, next most likely fetal distress, and then third most likely postpartum hemorrhage. So what law is relevant to the practice of nurse midwives in Washington state? So it shall be the duty of a midwife to consult with a physician whenever there are significant deviations from normal in either the gestational parent or in the newborn. That is one of the first lines in the law regulating midwife practice. And then every licensed midwife shall develop a written plan for consultation with other healthcare providers, emergency transfer, and transport of an infant to a newborn nursery or NICU, transport of an individual to an appropriate obstetrical department or patient care area. So for nurse midwives to be practicing in Washington state, they have to have a plan in place for how they are going to get the patient to the hospital, and they have to have some pre-existing relationship, and then they do have some pre-existing relationship with at least one of the hospitals, in a plan that if something goes wrong, this is where they're going to send the patient. So what is in a midwife's scope of practice? IV oxygen. They can provide nitrous oxide. They can use neonatal and adult resuscitation equipment and medication, specifically epinephrine for maternal anaphylaxis and resuscitation, and for neonatal resuscitation, and with the caveat that that is pending transport. And then they can use terbutaline to temporarily decrease contractions pending transport. So with the caveat that goes with any of these medications is that this is, with transport pending. This is not a stay and play approach. This is you give these medications with transport on the way. They also have access to a full suite of drugs for postpartum hemorrhage, and then magnesium sulfate for preeclampsia. So what are the key principles as far as how we interact with nurse midwives? So if 911 is contacted, we assume that an emergency is present, that there's a deviation from normal labor. The midwife has a duty to consult with a physician. You are operating under physician orders, and so you're fulfilling that role in the out-of-hospital birth. We recognize that you are the experts in pre-hospital resuscitation. But then we ask that you recognize midwives have significant experience attending births, at a bare minimum 55 births, which is hopefully more than any of us have done in the field. And then they do have access to some medications outside the EMS scope of practice, most importantly, the medications for controlling postpartum hemorrhage. And so the governing principles here are to establish teamwork, to recognize that if you're called, the midwife has said that this is a situation that they cannot manage at the home or the birthing center, and so you need transport. But then this is someone who has valuable experience with attending births, and particularly if you're dealing with something that requires hands on the gynecological organs. So if you have a breech birth with a presenting part, if you have a prolapsed cord, or if you're having postpartum hemorrhage and you need uterine massage, this is someone who's experienced in doing those things, who can do those things while you are doing the other things that you do, including resuscitating the infant and caring for the mother. And that the midwives also have some medications that can help to mitigate postpartum hemorrhage as you're working on transport. So we're going to continue to look for opportunities to smooth that interaction and to train well together, but we wanted to cover these key principles. What questions do you have about working with midwives in the field?
We want to reiterate or iterate to the medics that while the midwife who is in charge of the birthing center or in charge of the home birth, and so at that point they have now called for medical assistance, and so they understand, although sometimes in the heat of the moment they would be considering that they are still entirely directing the care of the patient, and then the midwife cannot legally give orders to the paramedic. The EMS is under medical physician control, just like we do not have anyone other than physicians write your orders. But in the heat of the moment when there's an emergency, everybody is excited and everybody has a need to have some sense of control. Our point is to give care to the patient, or in this case to two patients, and we do not need to fight among ourselves about how this happens. But so it takes in the one case that we used as our index for bringing this issue to the fore. There was initially a quite a bit of discussion, or not discussion, quite a bit of tension between the midwife and the paramedic, until that situation was diffused by another paramedic who said, "What do we need here? Let's get this baby transported." And then once in the, you can continue to ask the midwife to, or listen to the midwife's needs, but once you're in the ambulance, that is your territory. That's your, once you take over and you begin transport, you are in charge, and you are under your protocols. You can do anything within your protocols, and the midwife may say, "Could we do this?" You can do anything that's within your protocol. If you're doing something that's outside the protocol, you can't do that. If you do something outside the protocol, or if the midwife is suggesting that you're going down a pathway that you should, that you say, "I'm not sure this is working out," you then issue you're in charge, so you say, "We can contact medical control, but this is not within our protocol. I believe that this will happen if we go this way." And so you continue. You are ultimately in charge in the ambulance. Now, you can go through most of this. Most of these midwives will be more than happy to assist, to continue doing things. I mean, there's none of you that I want to see in the back of an ambulance with a hemorrhaging postpartum case. You do not have the training, nor do you have within your scope of practice to do a bimanual uterine compression. You've not been trained to that. So, I mean, basically, you stop at the vaginal orifice. You don't go any further than that as a rule. So you're not going to be as good as the midwife in managing that. But the big point is that we can work collaboratively. We're going to try to set up ultimately some trainings. There's a birth center now in Vancouver that we can expect to get some calls. As Dr. Mock said, these are very, very rare, probably only 2 to 3% of all births attended by a midwife in home or birthing center result in a call to 911. So we don't get to see most of what they're doing. But we're trying to arrange some joint training, which one of the things with, I mean, most deliveries work quite well, but there are enough complications that and I'm not sure how many births most of us have attended in EMS through an entire career, but I'm sure it's usually on one hand the number. So they far, just to get licensed, they have to have 55 births under their belt. So they're way ahead of the game at that point. One thing, Dr. Mock, I didn't notice, what is the infant mortality rate for deliveries in a hospital attended by a physician the same as for the nurse midwife?
It's similar, but obviously in a hospital, nurse midwife births are lower risk patients. So the physicians are also, if in a hospital, the nurse midwives will only attend lower risk births, and and ideally should be doing the same at home.
And of course,
But
if it becomes a high risk birth, they have a physician available immediately.
Right. And it is, births attended by midwives, even in the hospital, have lower rates of cesarean section. So there is, it's not that we as physicians are perfect. There are reasons to try to, to have a vaginal birth, and midwives have a lot of experience getting people through that. But it's it's what happens in these small number of cases where things don't go well that makes the difference in terms of mortality. Any other questions or comments about midwifery? Well, I'm very grateful for your time. I posted the link to give feedback in the chat. I have a QR code for that here as well. I really value your feedback, and I want to make these sessions as valuable for you as I can. So I have a 2-question feedback form, and I welcome any comments and suggestions you have. Thank you very much.
Thank you, Dr. Mock.
Thank you.